Now this is a very interesting CT scan of the brain where we can see very nice findings. First I'll start to show some of the normal structure that we should always remember. The brain or the skull is divided into three parts, that is the anterior cranial fossa, the middle cranial fossa and the posterior cranial fossa. It's very simple. The middle cranial fossa, this is all temporal lobe of the brain. So this is the middle portion. So this is middle cranial fossa which contains temporal lobe. The behind that, this is the posterior portion of the skull or posterior portion of the brain where we can see the brainstem structure. So here you will be able to see that is midbrain, pons, medulla and cerebellum. You also have reticular activating system in brainstem only, but it is very difficult to see that reticular activating system. It's very easy to find out the medulla, the lowermost portion of the brain which continues as spinal cord is medulla. So you can simply see the lower cuts. This is all medulla, this is all medulla, this is all medulla. So this will be all medulla. So above the medulla, the structure which is almost round or almost circular is pons. So when it comes here, see, this is almost complete structure. This is pons. This is pons, and this is all pons. The perfectly circular structure is pons, and above the pons, the butterfly shaped structure is medulla. Is midbrain. I am extremely sorry. This is midbrain. The butterfly shaped structure is midbrain. So this is midbrain. So you should always start reading CT scan by seeing these things first, because these things are very commonly forgotten. These infarct, bleed in this area, they are very commonly mistakenly lost or not seen. So you should always start reading the CT scan by seeing these things. Now just behind this brainstem structure is all cerebellum. This is all cerebellum. The middlemost portion of the cerebellum is vermis. This is vermis, and this vermis portion is mainly required for balance. So if someone gets bleed or ischemic stroke in this area, these patients very commonly have balance issue. And this is right portion, right cerebellum hemisphere. This is left cerebellar hemisphere. So this is left cerebellar hemisphere, this is right cerebellar hemisphere. If someone gets right cerebellar problem, the patient will have right sided incoordination of the limbs. If the patient gets left sided problem, bleed or ischemic stroke or tumor or lesion, the patient will have left sided incoordination, dysdiadochokinesia, intentional tremor. These symptoms this patient will have. So these are the brainstem structure. The other important structure that I told you, okay, this is middle cranial fossa. So this is temporal lobe. You can see this is the temporal horn of the ventricle. This is the temporal horn of the ventricle. This black structure is temporal horn of the ventricle. Now see, this is the these are the lateral ventricles. These black structures, these are lateral ventricles. That is the first and second ventricle, which contains CSF, and this has occipital horn, temporal horn. So this is coming into the occipital horn. So occipital horn you'll be able to see in occipital lobe, and temporal horn you'll be able to see in temporal horn. So this is occipital horn because this is coming into the occipital portion of the brain. So this is occipital horn, and these are two lateral ventricles. This is the first and this is the second lateral ventricle, and this is the occipital horn. And we have seen that this is the temporal horn because this is seen in temporal lobe. So you can identify now the temporal lobe. We need to find out the central sulcus. Now see, this is the sulcus, this is the black portion, which is the most large portion in the brain, the largest sulcus of the brain. See here. So this is the sulcus, which is the most largest sulcus. This is called central sulcus because this comes in almost central, and this is the largest sulcus of the brain. So in front of the central sulcus, so see, this is the largest sulcus, this is the largest portion where there is no brain, and this central sulcus divides brain. So this all anterior frontal portion is frontal lobe, and this is the lowermost portion of the temporal lobe. You can see this is the continuation of this middle cranial fossa. This is the small portion of the temporal lobe which is remaining. So this is the temporal lobe, so this is the temporal lobe, this is the temporal lobe. So uh, anterior to the central sulcus you will have the frontal lobe, posterior to the sulcus, this central sulcus, you will have the temporal lobe, and above this area where, see here, there is no fossa, there is no fossa, so the temporal lobe is gone. Now what you will see is all parietal lobe. Here you will have all parietal lobe, and very much few portion of the frontal lobe, but this is all parietal lobe. And the upper cuts, these all upper cuts, they usually only have the parietal lobe only. So, and when you have end of this cerebellum, so this is the midbrain, so behind that the horizontal sulcus where you have, this is all cerebellum, this is all cerebellar portion. As soon as this cerebellum is lost, what you have is occipital lobe. What you have is all occipital lobe. So you can see this is the occipital horn of the ventricles. So this is all occipital lobe which is required for vision. One of the most other important structure which I want to show in this CT scan is the caudate lobe, is the thalamus, which are very important structures. So uh, one of the most important structure which we can see in this image is we have to localize this lateral ventricles, and just behind or below this lateral ventricle, a small almond like structure is caudate lobe, which is a portion of basal ganglia which is required for movements of muscles. So if this is involved, very commonly patient may have abnormal movements, or patient may have paralysis of a particular movement. And just behind this caudate lobe, the larger almond shaped structure is thalamus. This is all thalamus. So how you can remember thalamus is, in between the two thalami you have the third ventricle. So this is the third ventricle, this is the first, second ventricle, this is the occipital horn of the ventricle which is a portion of first and second ventricle, this is the third ventricle. Because fourth ventricle you will get at pons level, you will get at pons level. So first, second, third, fourth ventricle you get at the pons level. This is the circular portion, you have the fourth ventricle, and these are the first and second ventricle, and third ventricle you will have in between the thalami. So you can simply see that this is the third ventricle, and that is the reason why these are the two thalami. So what we have seen ki outside this thalamus, you can see, just focus on this area, when we zoom in, this was the caudate lobe. See, this is the area of thalamus, this is the right thalamus, and uh, here is what we have is putamen and globus pallidus, which is a portion of basal ganglia. Basal ganglia stores all the programs for the movements. So if Sachin Tendulkar can play a very beautiful shot, if any footballer can play a very good kick, that is because that program of shooting with that much precision is stored in this basal ganglia. So whenever someone gets damage to this basal ganglia in the form of infarct or bleed, that patients lose the ability to move that limb. So very easily to remember, just remember this, that the patient has this lateral ventricles, you have caudate lobe here, which is a portion of basal ganglia. Exactly behind this there are two thalami, and here you have the putamen and globus pallidus, which is a portion of basal ganglia. So caudate and this putamen and globus pallidus, these two things are called basal ganglia. This is thalamus, this is thalamus. So in between this structure, what we have is internal capsule. This is called internal capsule because sorry, I'm extremely sorry for this. This you will not have this here. This you have internal capsule because you have external capsule in this area, and in internal capsule this portion the patient has nerve supply of the facial muscles, and here you have involvement of the leg muscles. So very commonly whenever someone gets bleed or hemorrhage here, the facial muscles, leg muscles and arm muscles are very commonly involved. The thalamus is more of involved in arousal, awareness, and it is also involved in all the sensory fibers of touch, pain, pressure and vibration. So if someone has the bleed or infarct in the thalamus, then the patient may lose ability to have sensation of this touch, pain, pressure, vibration or joint position sense. So patient may complain of weakness, but the patient may not have weakness, but because of lack of this sensation, the patient may think that he has weakness. So in this particular patient, what patient has is, if you can see, if we have already seen in this image, when we zoom in, this is caudate. So this was actually thalamus. So here the patient has bleed in the thalamus, and this is the area of internal capsule. So this thalamic bleed is actually compressing in the area of internal capsule, causing compression of the facial fibers, lower limb fibers and upper limb fibers as well. So this particular patient was presented with, he was a known hypertensive, and he presented with right upper limb weakness. His upper limb weakness was only grade 1 out of 5. He could not move his upper limb, right upper limb against the gravity. His right lower limb power was better. It was around 3 out of 5. So he could move his limb against the gravity, but with not that much force. He had slurring of speech and he has facial weakness as well. He was conscious, he was obeying, but he had tendency to sleep. So this is very typical hypertensive bleed. How do we come to know hypertensive bleed? Because in hypertension we have a mnemonic which is called PTPC, that is putamen is the most common site of hypertensive bleed, followed by T, which is thalamus, which is the second most common site of hypertensive bleed, followed by pons, which is the third most common site of hypertensive bleed, followed by fourth, which is cerebellar hypertensive bleed. So this case illustrates left-sided thalamic bleed causing compression or genu fibers of internal capsule and posterior limb of internal capsule with mass effect, but with not without any significant midline shift, because the because the cerebral structure are almost at the same place. There is no significant midline shifting of any cerebral structure to contralateral side. Thank you.